I'm Tim Norbeck, CEO of the Physicians Foundation, and I think we have a very interesting and timely program for you. The Physicians Foundation came into being 10 and a half years ago as a result of a massive class action lawsuit brought against health insurers by physicians and medical societies. Insurers had been delaying, denying, downcoding, and bundling physician claims and arbitrarily making medical necessity decisions. These egregious actions were very costly to physicians and impacted the care given to their patients. Attempts to iron out these differences with insurers proved fruitless. Physicians and their medical society received what I would call the Fibber-McGee treatment. In the old-time radio show of the 30s, 40s, and 50s, Fibber-McGee often complained, as he put it, that my wife and I had words last night, but I never got to use mine. So it was with our one-way discussion with insurers. From the states of Washington to Florida, Maine to California, and everywhere in between, I think there may be a song like that, state medical societies went to their state legislatures to secure meaningful managed care reform and right those wrongs. We were all successful in achieving some reforms in our respective state legislatures, but the problems did not go away because the insurers simply ignored them. In the end, in the late 1990s and in 2000, 2001, the only remedy left to us was to bring a massive class action lawsuit against the health insurers. The suits were remanded to the federal court in the Southern District of Florida, presided over by Judge Federico Moreno. Settlement was achieved first with Aetna on May 21, 2003, and the Physicians Foundation, the creation of which was one of the terms of the settlement, first met in December of that year. The past 10 years have been interesting and successful for the foundation. We have given over $31 million in grants and have commissioned a number of white papers on a variety of subjects relating to physicians, patients, and our healthcare system. Just one of our more significant grants is one awarded to the Cecil G. Shep Center for Health Services Research at the University of North Carolina at Chapel Hill. The grant is to develop a web-based project model that enables users to estimate physician supply and demand within a set geography and or specialty. This future docs forecasting tool estimates the supply of physicians, use of healthcare services, and capacity of physician supply to meet the healthcare services needed in the United States. It is an important and innovative step forward for healthcare workforce models because it is interactive, web-based, and user-friendly. We will share this information with all interested parties, including members of Congress and the Department of Health and Human Services. In addition to grants and white papers, the Physicians Foundation has conducted biennial surveys of physicians to assess current physician attitudes and practice patterns. Dr. Walker Ray will fill you in shortly on the Physician Survey Project. The Physicians Foundation will also be conducting a biennial patient survey beginning next year. The relationships with insurers, while still challenging, have improved over the years since the settlement of the suits. In fact, we have a physician representative of Aetna, Dr. Jim Cross, serving on the Physicians Foundation board. However, the medical practice environment for physicians has become even more imperiled for different reasons since those which prompted the lawsuits. As Walker Ray is sure to mention, by an overwhelming number in all of our physician surveys, the experience that physicians find the most satisfying in their medical practice is the relationship they establish with their patients and the time spent with them. And yet, as our expert panel will soon explore along with other issues, that cherished patient-doctor relationship is under siege today. Because of increased regulations and red tape, physicians have less time to spend with their patients. They now spend on average 20% of their time on non-clinical paperwork, whether it is on credentialing, formularies, claims billing, pre-authorizations, or quality measuring data. And time spent on administration will only increase with next year's implementation of the ICD-10 codes in October of 2015 a veritable nightmare for physicians. The number of diagnostic codes from which physicians must select will increase from about 14,000 to roughly 69,000 codes. 75% of physicians responding to our recent 2014 survey says that it will unnecessarily complicate coding as well as increase the already excessive amount of time spent on non-clinical work. With so many Americans hurting economically, we all recognize that it is difficult for people to sympathize with others having problems. After all, as Lou Holt said, most people don't care about your problems, and the others are probably glad you have them. Patients should be concerned, however, about the diminishing time that they will have with their doctors due to these increasing administrative burdens. In her new book, What Doctors Feel, New York internist Danielle Ofri reports that U.S. physicians in non-hospital medical practices spend 10 times as many hours on non-clinical administrative duties as their Canadian counterparts do. Dr. Gerard Giannoli reflects the opinion of so many physicians when he said that medical practice should focus on the deeply personal decisions made between doctor and patient, but as he explains, today's bureaucrats are inserting themselves into every single aspect of healthcare. Physicians across the country are responding to these intrusions, in part because of the Affordable Care Act, by attempting to shield their practices from government interference. It has come in many forms, rejecting new Medicare and Medicaid patients, transitioning to practices free of third parties, and reluctantly leaving private practice for employed physicians with ever larger hospital-owned networks, which, incidentally, only add costs to our healthcare system. Many physicians today complain that increased regulations only serve, as Dr. Jason Fodeman puts it, to shift the physician focus from patients to paperwork, from finding cures to filling out and filing documents. Filmmaker Woody Allen seems to have taken a page from the healthcare regulator's playbook when he said, "If my films make even one person more miserable, I will feel that I've done my job." To further exacerbate the situation, Medicare has increased the payment rate to physicians by only 4% since 2001, 13 years ago, while the cost of operating a medical practice has risen more than 20%. And consider that more than half of Medicare beneficiaries have 5 or more chronic conditions, and that 10,000 Americans are being added to the Medicare rolls every single day. This does not bode well, of course, on top of a growing physician shortage. In addition to all of this is the threat of deep cuts under Medicare's SGR, or Sustainable Growth Rate formula for paying physicians, and the ACA's $415 billion in cuts over the 2013 to 2022 period to physicians, hospitals, and nursing homes, hanging over physician heads like the sword of Damocles. Before I turn over the podium to Dr. Ray, I did want to mention my experience this past weekend. I was walking my dog in this dog-friendly mall where I live in Southwest Florida when I saw a middle-aged man wearing an interesting T-shirt. I wanted to go up to him and say, "I'll bet I know what you do for a living. You must be a healthcare regulator." The bold print on his shirt said, "If you are agitated and confused, my work here is done." Dr. Walker Ray is the Vice President and Chair of the Research Committee for the Physicians Foundation. He's a retired pediatrician with over 40 years of experience practicing medicine in Georgia. He also currently serves as the president of the Physicians Institute and is a past president of the Medical Association of Georgia. Dr. Ray has particular expertise in the areas of pediatric primary care medicine and the broader array of societal and economic issues impacting the physician's practice of medicine. Walker?
Thank you, Tim, and good morning to everyone. It is a beautiful day with a beautiful view behind me. I hope you will not concentrate totally on the view. First, let me thank everybody for being here. Many of you are giving up personal and professional time. Some of you have traveled a great distance, and I think it's worthwhile acknowledging that that's the case. So thank you for being here, and thank you for your attention to my discussion of our 2014 Physicians Survey. To begin with, I'd like to borrow a figure of speech. One of the things that we say that in 2014, to be a physician is to feel the ground shaking under your feet. This is a reference to the historic changes that have occurred in the last 2 or 3 years. A tremendous time of transformation within healthcare. It is, we would be hard to be put upon to remember a 2 or 3 year period where there had been more changes within the medical healthcare environment, particularly the doctor's office, between the patient and the doctor, than the last couple of years. It was during this period of time that we did our 2014 survey, and this reflects in a number of things: the practice plans, the patterns, the insights, the perspectives of physicians. We could put up slide 2. We have probably the largest survey that's ever been done of physicians. Certainly one of the largest. 630,000 physicians were surveyed over a period of spring and early summer. We had 20,000 plus respondents, have a very low margin of error, plus or minus 0.78%, which is 1 to 2%. It's been validated as a very credible survey, a survey that you can believe by survey statisticians who specialize in evaluating survey modalities and reliability. We are interested not so much in whether doctors are happy or unhappy, pessimistic or optimistic. What we're interested in is, how does this relate to access to care? How does this relate to what all of us in the room want when we need it, and that's the ability to access a physician in a timely manner, with the proper time, and with quality medical care. We clearly find something in the survey that has been validated by other surveys, by our other surveys, and what we constantly hear on the ground through our communications network. As Tim intimated, we are coast to coast. We have seats on our board from Alaska, Hawaii, California, Washington State, the New England states, up and down the eastern seaboard, the Carolinas, Northern Virginia, Georgia, Florida, Texas, Nebraska, Colorado, Louisiana, Tennessee. And what we hear, and this would be slide 4, I believe, Jason, is that physicians are expressing disaffection and dissatisfaction, pessimism, excessive pressure, unhappiness, and low morale within their individual practices. Now, we might ask, why would this be? Why is this the case? Let's look at slide 5 to see what that would be. Slide 5 shows 8 factors that affect morale. The last 2 are particularly important because they are reflections of this survey and information that we found at this particular time. The top 6 are related to data that we have from other surveys. This is not totally inclusive. There are many others that probably those of you in the audience here could recommend or add to the list. But let me read the list very quickly. There are high levels of government mandates and regulations, malpractice liability pressures, declining reimbursement in an upside-down model where now physicians are to be paid by value of services rendered, whereas value has been poorly defined from physicians' point of view, as opposed to volume of services that are rendered. There's a sense of powerlessness to influence change and an uncertainty caused by healthcare reform. We know that powerlessness and uncertainty both tend to promote inaction, sometimes even paralysis, certainly frustration. There's the ever-present lack of personal time due to practice demands. But the last 2 are particularly important, I think: the diminishing time spent with patients and the erosion of clinical autonomy. In the survey, We notice that 69% say that their clinical decision-making process is compromised or restricted or limited in sometimes or frequently in their practices. This means that physicians aren't always able to, as they wish they could and want to, and as we as patients want them to, be able to use the best judgment for the patient based on their experience and based on their training, based on their education, and based on their specific knowledge of that patient. That causes frustration. The diminishing time spent with patients, as Tim Norbeck intimated, is a significant problem. The famous physician, Sir William Osler, Canadian physician who was one of the founders of the Johns Hopkins Hospital in Baltimore, the father of residency programs. Sir William Osler is quoted by people all the time, and every medical student has heard of Sir William Osler. He actually took didactic medical education in the classroom and brought it to the wards. So he's called the father of residency programs. One of his famous quotes that is appropriate here is, "Listen to the patient. They will tell you the diagnosis." It's worth repeating. Listen to the patient. They will tell you the diagnosis. You've got to have time to listen to the patient. In today's hurly-burly practice atmosphere, there's not always that time. And that has to do strong implications with quality of care. Now, there are 4 challenges for physicians to adapt and cooperate and coordinate and engage in healthcare reform. This would probably be slide number 6, Jason. Thank you. These 4 challenges are pillars of healthcare reform. They are essential elements. They are ACOs, the physician employment model, EMR frustration and inefficiency, but let's just say EMRs at this point, and then the health insurance exchanges. What I'd like to do is let's look at how physicians are engaging or attempting to cooperate with healthcare reform. I want to present physicians as not being obstructionistic here. I want to present them as attempting to cooperate and engage and become involved. But they are obviously having some issues here. First, let's talk about ACOs. 26% of physicians, according to the survey, now participate in an ACO. Extrapolated to the physician population, that's over 200,000 physicians. Kaiser Health News says that 38 to 43 million Americans get their care through an ACO now. And almost half the country lives in a population area geographically where they could receive care through an ACO. So physicians are attempting here to cooperate. 53% of physicians are now in an employed status. The interesting metric there is this was 35% 2 years ago in our 2012 survey. This is a tremendous and rapid immigration path out of private practice to an employed status. 85% now have implemented EMRs in their practices. That was a surprise to us. This is up from 69% just 2 years ago, and up from 30% maybe 8 or 9 years ago. I remember when President Bush appointed David Brailer as the first health information technology czar. The goal was to get this degree of EMR implementation in physicians in 10 years, and that's been accomplished. As far as the healthcare exchanges go, we wanted to know how physicians were doing there, and we find out that there's a great deal of uncertainty. It's hard to draw conclusions, but I want to come back to that. First, let's look at slide 7. This issue here is how are physicians adapting to, not whether they are attempting to cooperate, but what is their experience with ACOs. If you see here, according to the slide, 12.7% feel like ACOs are going to work. For ACOs to work, they've got to increase quality and decrease cost. Otherwise, they don't justify the massive expense and structural issues that go into the superstructure and infrastructure and large number of employees in an ACO. So only a little over 1 out of 10 physicians really feel like they're going to do the job they're supposed to. Look at line 3. 3 times that many feel like it's not going to work. They say just flat out it's not going to increase quality. It's not going to decrease cost. 19% say, line 2, that if it does do some good, the organizational gains of cost and quality will not be justified by the expense or by the trouble for this to occur. And this was a surprise to those of us at the foundation, line 4. 32% are unsure about the purpose or structure of ACOs. Now, that's surprising because physicians are not unsophisticated people. They're not uninformed. In fact, I'm always surprised and admiring when I talk to my fellow physicians how much they know. And yet, 2 years ago in our 2012 survey, this figure was 28%. So it's increased by a little bit as far as the uncertainty goes. All right, let's look at the physician employment model. I believe that would be slide 8. We asked if physicians felt that this was a positive trend, being a hospital employee, and 63% said no, it's a negative trend. Only 37% said that they were positive about that. It's not on the slide, but if you break it down, the very positives and the very negatives were less than 10%, and the very negatives were around 35%. So 3 or 4 times as many were very negative as were very positive. Further of interest is if you just look at the hospital-employed physicians and ask them this question, 50% of those are negative, that this is not a good thing. EMRs, first let me say that this is not a rant against healthcare reform, nor is it against EMRs. EMRs are here to stay. Doctors are not going back to paper, and EMRs have a lot of potential. What we're asking physicians is, what is your experience with EMRs? Again, we said that 85% of physicians have implemented these systems, up from 69% just 2 years ago. But less than a third say it's improved quality in their practices. About a fourth say it has detracted from quality in their practices. About the same number, 24%, feel that EMR has improved efficiency, but almost twice that many say it has decreased efficiency. What is surprising to me and to the foundation and is of concern are the next 2 metrics. 4.6% of physicians say that EMRs have improved patient interaction. 10 times that many say it has detracted from patient interaction. Back to Sir William Osler. Listen to the patient. They will tell you the diagnosis. As far as the health insurance exchanges, as I intimated, there's been significant confusion here as we attempted to find out how that was working for physicians. About 1/3 of physicians participate in health insurance exchanges, but almost that many say they have no plans to participate, and 28% say they are unsure of whether they participate in a health insurance exchange. There's been a lot of talk about restricted networks where physicians are not allowed to participate in an exchange under certain circumstances. They've been profiled in many ways, and many times they're not told why they can't participate. It's called a restricted network, and you'll hear that term over and over again. 63% of respondents say they don't know whether restrictive networks are in their state or not. Again, a lot of confusion and uncertainty. And this is not on the slide, but of those that say that their state has a restrictive network, about 1/3 of them say that they don't know whether they've been restricted or not. I don't think we can say much about how the exchanges, because of this information, are working for physicians, but we can say that there's uncertainty and confusion. Again, uncertainty and confusion may lead to inaction and frustration. All of the things that we've mentioned here, including the 8 items that lower morale, have to do with interfering with the doctor-patient relationship. As Mr. Norbeck told us, The reason that physicians go into medicine is patient relationships, far and above all others. We found this on survey after survey after survey. Other reasons they go into medicine are perhaps prestige of medicine, intellectual stimulation, financial rewards. These are all down around 15 to 20%. Patient relationships is up there around 80%. This is the aspect of medicine that gives physicians the most professional satisfaction. Therefore, we can understand how when patient relationships are compromised, morale suffers, and we have the issues of pessimism and issues in practice that are concerned. This is all reflected in slide number 11, which talks about physicians' respondents' evaluation of the ACA itself. If you look at these numbers, 25% give the ACA, the Affordable Care Act, a good grade. Almost twice that many give it a failing grade, 46%. A mediocre grade, C, 29%. But look at the best grade, A, 3.7, the worst grade, F. About 7 times as many give it an F as give it an A. Perhaps we begin to understand why that's the case. Let me wrap up. There's so much in the survey. I hope I will have potentially encouraged you to maybe look at it. There are over 1 million data points in the survey. There were 36 questions. Many questions had multiple possibilities as far as answers. It has been subdivided by gender, by age, by practice status, by practice type, so you can find out how each group of physicians feel about a certain issue. But to summarize, survey tells us that 56% of physicians will continue to practice in the next 1 to 3 years as they are now. But 44% will make substantial changes within their medical practice environment, which may interfere with patient care. It may diminish the physician workforce. These changes involve 18% will cut back on hours, 9.4% will retire, 7 or 8% will cut back on patients seen, 9 to 10% will do locum tenens, which will restrict the number of patients they see. Over 10% will remove themselves from seeing patients' clinical care and go into a administrative position within medicine. If all of this occurs, this would reduce the physician workforce, not just by tens of thousands of physicians, but by as many as 100,000 to 150,000 physicians at a time when the population is growing larger. By my calculations, about 2.5 million citizens a year are being added. The population is growing older. As Tim intimated, Medicare, I believe 11,000 individuals a day are now becoming eligible for Medicare and will for the next 18 years. People that are older, such as myself, go to the doctor more often. When I was young, I went to the doctor every 2 or 3 years, maybe not that often. Now it seems like I'm going every month for one thing or another. Population is also becoming more widely insured. 8 million new patients approximately last year through healthcare.gov and 5 million through Medicaid. This is at a time when we have a physician shortage. We know we've had a physician shortage for a number of years. The foundation has been interested in this and published on this for many years. 72% of physicians in this survey said, we agree that there's a physician shortage and we agree that the residency cap on physician funding training needs to be lifted. As most of you know, the residency cap has been there since 1997, the balanced budget amendment, and that was on 1996 level. So we are now 18 years of training essentially the same number of physicians. Now, the fact that 72% of physicians would say that this should be lifted is a compelling number because it would be an advantage competitively, you see, for physicians to limit the workforce. That's not what physicians are saying. They're saying we need some help. 81% of physicians report that they are at capacity in their practices now. Of those, 50% say they are at capacity. Another 30%, to equal the 81%, say that they are overstretched and overworked and have no time to see new patients, take on new duties and tasks. We know what's happened in the VA system. I won't go into that other than part of a large basic part of that problem was a capacity problem to see the patients. People have suggested perhaps that maybe the private sector could take up the slack. We don't know or think that there's much capacity in the private sector for that to occur. In fact, what has occurred in the VA system could theoretically occur in the private sector. Physicians are seeing 17% fewer patients over the last 6 years. We know that from the survey, and they're working 6% fewer hours. These findings, I think, underscore the importance of protecting the medical practice environment and the relationship between physicians and patients. What do we need to do about this? What are the remedies? The remedies are so simple that everybody knows what they are. The diagnosis is easy, it's the treatment that's hard. The diagnosis is we need to train more physicians. There's not the political will to do that at this point. And the issue with that is once you decide to train a new physician, you turn on the spigot and the physician comes out about 12 or 15 years later. You don't have an immediate supply of physicians waiting to be trained, so to speak. So we need to protect the medical practice environment for the patient's benefit, for the doctor's benefit, so that we all can stay together and receive quality care. I'm no longer an active physician. I'm an active patient. And I want my care just like you want your care for you and your families. Thank you for attention and listening to me. I appreciate it. It has been fun for me to talk to you. I hope it's been half as much fun for you to listen to me as it has been to speak.
Thank you very much, Walker. And as Walker said, and I will say again, that more physicians responded to that 2014 survey that he cited than any other that we know of. We've now reached the panel discussion portion of our program, and Joe Valenti, MD, will be the moderator. Dr. Valenti is a board member of the Physicians Foundation and an OBGYN with 16 years of private practice experience. He currently practices at Caring for Women in Denton, Texas. In addition, Dr. Valenti is the chair of the Council on Socioeconomics for the Texas Medical Association and previously served as the chairperson of the TMA Committee on Maternal Prenatal Health. Joe?
Thanks, Dave. Thank you all for being here. Really appreciate it. This is going to be a lively and fun discussion. At the end, we're going to open it up for questions and answers. Let me introduce our panel. Dr. Susan Bailey, come on up. Dr. Bailey is an allergist in private practice at Fort Worth Allergy and Asthma Associates, and she currently serves as the Vice Speaker of the House of Delegates for the American Medical Association. She's held numerous positions at AMA, including Chair of Council on Medical Education, Chair of the Texas Delegation, and served as the representative to the Assembly of the American Board of Medical Specialties. And previously, she served as the President of Texas Medical Association. Sue, thank you for being here. Next, Dr. Robert Basil. Dr. Basil has practiced family medicine in rural Minnesota for more than 30 years, and in 2008, he joined Stevens Community Medical Center. He's a clinical assistant professor at the University of Minnesota, who has also received numerous awards, including most recently the 2013 Country Doctor of the Year, presented by Staff Care. Additionally, Dr. Basil served in Vietnam, so one of our cherished veterans. Thank you, Dr. Basil, for your service. And received the Army Commendation Medal, the Combat Medical Badge, and Purple Heart as a combat medic. Dr. Basil. And finally, Dr. Dev Sangvi. Dr. Sangvi is the Associate Chief Medical Officer for Duke University Health System and Medical Director of Duke Well, a population-based health program for Duke employees and dependents. He also serves as the Executive Director of Duke Connected Care, a Medicare Shared Savings Program, ACO, and an Assistant Professor of Family Medicine, Pediatrics, and Psychiatry at Duke University Medical Center. Dr. Sangvi. So as you can see, we've got a relatively diverse panel here, so I want to dive right into some of our topics. The first thing we're going to discuss is the current practice environment. So I'd like you all to get a flavor for what we're seeing. Things are changing considerably, as you've heard, and a lot of new quality measures, a lot of new technologies, a lot of new reporting requirements, payment models. The list is going on, and you can imagine for private doctors this is really challenging. So let's start with Dr. Basil. Where are you with your practice today? How are things going compared to what they were 5 years ago, Dr. Basil?
Well, I think it's going great. I'm moving a little bit slower than I used to. Some of it is age. Some of it is the impediments of the bureaucracy of medicine. Mm-hmm. I still make house calls, deliver babies, do EPIs. I'm a Renaissance kind of physician that way. None of that has changed, but the impediments of bureaucracy, prior authorization, all these things have made it such that I cannot see the number of patients that I used to. That's probably the biggest change.
Yeah. Dr. Bailey, what do you like and dislike most about practicing medicine in the current environment?
In the current environment, well, the one constant over every environment really is the magic, the joy of the physician-patient relationship. Mm-hmm. That has not changed. It's the greatest honor and I think the greatest privilege imaginable to be asked for someone to take care of to give you their health in their hands, as it were. And I think the challenges are that there seem to be so many more people in the room now than just me and the patient. I can't just write a prescription. As an allergy and asthma specialist, I write a lot of prescriptions because medications are the foundation of a lot of what we treat. I can't just do that anymore. I've got to know, well, which insurance company do you have? What's on their formulary? What's the first choice on the formulary? What's the second choice on the formulary? And then have to fill out forms to ask permission and see if that permission is granted for the medications that I feel are most appropriate to be given. The prior authorization process just drives me nuts. Mm-hmm. A lot of doctors won't do it. They just think, okay, it's not my fault that your insurance makes you do this. I don't feel that way. I fill out every prior authorization form that I can. I fight them because if you don't fight, the insurance company wins. And but having to ask permission to do what you think is best for your patient is really, really aggravating. It takes a lot of time.
I share that frustration with you as well. Dr. Sangvi, ICD-10 is coming. What do you think that's really going to add to patient care?
I'm not sure it's going to add a whole lot. We heard earlier that we're going to add 55,000 codes. Coding is already a challenge for physicians. I think what we're going to have is increased bureaucracy. There is a belief that the EMR solution is going to be a way to get through ICD-10, but as we saw in some of the data, EMR is yet to kind of get the kind of return we want on it. So I'm not optimistic that we're going to get a whole lot out of ICD-10, given that it's not really designed to improve patient care, but improve documentation and coding.
Mm-hmm. Agreed. Let's move on to the topic of morale. We heard a little bit about that earlier. I want to ask each one of you, how have you managed to keep a positive outlook given all the change? Sue?
Once again, it's about the patients, and the patients are what keep me going. I can be having a terrible day, be arguing with an insurance company, upset about something else, but when I'm in that exam room with that patient, nothing else really matters. It's still, I think, the greatest profession, and to realize that you have that opportunity to help someone is what gets me up and gets me in that office every day.
Yeah, Deb, what keeps you practicing medicine? What makes you feel like you want to keep going?
It's the same thing. Most of what I do now is administrative, so the opportunity to actually have one-on-one interaction with patients is exponentially rewarding, but it's exactly what Sue said. It's the ability to have that relationship, to impact someone's health, to share health goals together, to see patients make progress. That's what keeps me going. I also find that we are in an era of profound change, but profound opportunity as well. And there are some opportunities for physicians to be collaborative and innovative, and those opportunities, when secured the right way, can really make a difference. So that's what gets me excited about what's happening in today's healthcare environment as well.
Bob, how about you?
Again, the sacred relationship between physician and their patients, of course, but also the intellectual challenge of whatever is behind door number 2, because you don't know. And it's one of the things I try to get across to medical students and residents as I teach them. You just never know what's behind door number 2.
Yeah, very good. Let's talk about patient access and the patient experience in the office. The foundation, as we've said many times, found that 80+% of doctors say the number one most satisfying thing for them is their experience with their patient. For me, coming in to see patients post-operatively and finding out they feel better, to me that's the yes, that moment of triumph. And again, you've heard it before, but it's more than the intellectual stimulation. It's more than the financial reward. Give me an anecdote. Do each of you perhaps have an anecdote or a story about how things have changed now compared to where they were, say, 5 or 10 years ago about the interaction with your patients in the office, Dev?
Sure. I think for me, I have to actually go back to 10th grade and realize that my typing teacher was in fact correct, that I am going to need that skill in the future.
I told the patient that the other day. It was very funny. I never knew typing would be so important.
Exactly.
Yep.
So, and it really gets to the idea that we are using EMRs more, and I think those that are more facile with typing can have that ability to type and make eye contact with anything other than the monitor in front of you. So I think from an anecdotal perspective, what's changed for me is the reality that you're treating a patient, not documenting the old way. So some patients will call you out on that and say, are you taking care of me or are you taking care of your computer? And it's, and I want to say it's them, but no, it's. I think that's the biggest challenge is learning how to use the EMR as a workflow tool as opposed to a documentation tool.
Yeah, Sue, what are you seeing in the office with your allergy patients?
It's very similar, and I love the comment, are you taking care of me, you taking care of your computer, because in reality we are doing both. Right. And there are so many parallels. The American Medical Association did a study with RAND last year looking at physician satisfaction and practice sustainability. And there are so many parallels in the findings of the AMA RAND study and the Physicians Foundation study. And EMR usability or lack of same was just right at the top of the list in terms of physician frustration drivers. And just the ability just to sit back and listen to the patient as opposed to, I'm glad I took typing in 10th grade too. Although I hated my mother for it at the time, because she made me.
You thank her now.
Yeah, every day. And so I am able to look at the patient and type at the same time, but I realize, not a lot of my colleagues are able to do that. And just the new things that you have to think about, I mentioned the formulary pressure, getting everything in the EMR. Oh my gosh, am I going to meet meaningful use? Am I going to check off the right boxes? Do I have their BMI on the chart? And and important things, but it makes the work process in your mind work a little bit differently. Mm-hmm. It's going to take a while. We just adopted our EMR in July, so we're very late adopters, which is fine. But because I think we ended up with a good product, but it's I worry that I'm going to miss something because I'm working so hard to check all the boxes.
Bob, do you think patients today, when they come into the office, do you think they're more informed or less informed or misinformed about their care compared to where they were before?
I think they're better informed about their care. I think we're doing a better job at involving the patient in helping them understand it. So I think the actual healthcare they're better informed at. The part about insurance and so forth is another story, and that's been very problematic and driving a wedge in the relationship between me and my patient. My patients somehow still consider me to be a deity, and indeed I can walk on water, at least in Minnesota for the next 6 months. But I end up deriving the blame from my patients now for prior authorization that doesn't go through. It's my fault. It's my fault, or as a medical profession, that we've allowed the status of all this bureaucracy to occur. Patients are fed up with that, and unfortunately, sometimes I get the brunt of that blame.
Right. I have a question. Do any of you think that if you had a practice based on just Medicare and Medicaid patients, and you were in private practice, could you keep that practice going financially just based on that?
I think it would be very difficult.
To me, it'd be impossible. The payments are so off that
If we're just Medicare, I could. I'd break even anyhow.
you wouldn't take them, you'd break even.
Yeah, I mean, Medicaid, I wouldn't. My understanding was the Affordable Care Act was supposed to bring up Medicaid reimbursement to Medicare levels. In Minnesota, 99213 now is $71 for Medicare. For Medicaid, it's still $55. And then they do silly things like send the patient a check for $100 if they have a mammogram. They don't even pay that much for me for the preventative exam for the year.
Right.
So the way money is spent is very misplaced.
Agreed. Yeah.
Well, the fact of the matter is that Medicare and Medicaid reimbursement very often do not account for and keep up with the cost of running a practice. And I think that our most important legislative priority is to fix the SGR, the sustainable growth rate, which is neither sustainable nor does it grow. And it has been broken from day one. And we have had 18, we're coming up on 18 patches of this thing.
Kicking the can down the road.
And have spent more money on the patches than it would have cost to fix it in the first place.
Right.
And so that's the sort of Damocles that we've got hanging over our head. And until we can get Medicare payment right, a lot of this other stuff isn't going to matter, because one thing the foundation survey showed is that there's been a significant decrease in the number of physicians that are seeing new Medicare and Medicaid patients. And although CMS tends to deny this, I think that the numbers are irrefutable. You cannot keep a practice going by just seeing Medicare and Medicaid patients.
Now, we have to take a referral. When I tell my patients that payments to doctors in the decade of 2000, 2010 went up 3% and to hospitals went up 30%, they're shocked by that. They said, well, why is it not equal? I said, well, you tell me. I don't really know the answer to that. So let's talk about the topic of career plans, career trends, employment patterns. 2 in 5 doctors say they're going to accelerate their retirement based on the changes in the healthcare system. And when you look at the fact that 8 out of 10 doctors are saying they're either at capacity or overextended, and they're looking for some alternatives, we've seen people doing different things. Dr. Basil, tell me about what you ended up doing with your practice.
Well, over the years, I've been in private practice. Joined a hospital, or merged with a hospital, ended up back in private practice, and more recently merged again. And the question really is, how does this work out? And the best way to explain this is to talk about Ole and Lena, who got married, got back from their honeymoon, and things were settling in. A week later, Lena says, Ole, why are you cleaning your golf clubs? You're not going to be golfing anymore now that we're married, are you? And Ole says, you're starting to sound like my ex-wife. And Lena said, I didn't know you were married before. And he said, I wasn't. When I merged with the hospital on this occasion, that kind of marriage, there are some lines drawn. And in my present practice situation, the organization tells me nothing about how to practice medicine. I can refer patients to anybody I want to, even the bozo in the other clinic down the road. There's no pressures whatsoever to stay within my system. If the best thing for the patient is go to another community, that's fine. And that's
often not the fact at a lot of systems, though, is it? In most places, the doctors are restricted from referring.
But if they start messing with me, I can walk away. I'm an old guy, I can retire.
And you've done it before, right?
Yeah, I've done it before.
Dr. Sangvi, you are the Associate Chief Medical Director for a large health system, and you integrate doctors in from private to employed situations, and then sometimes they go back out. What do you hear from them about how is now compared to being independent previously, and what do you hear about them? What do you hear from them about decreasing autonomy, increasing paperwork?
Yeah, that's a great question. I think that whenever you're looking to go from an independent practice to one where you might be part of a health system, you've got to do it for the right reasons. The physician really has to do it for the right reasons. And I think the marriage metaphor carries over that, if you're doing it for the right reason because you want to have some level of convenience, you're going to have to give up some level of independence. And I think it depends on what sort of independence you cherish. If your independence is to develop your own policies and protocols, that might be something you give up because the system is going to have its policies and protocols. But if your independence comes from having meaningful relationships with referring doctors and so forth, as Bob outlined, that may be something you don't give up. So I think that when you're looking to go from an independent practice to one that's part of a larger system, you got to do it for the right reasons. Both parties need to understand why that relationship is being struck. If the physician is doing it simply because they're disillusioned with medicine and frustrated, they're probably going to get frustrated in any practice model. But if they're looking to give up something and get a little bit, then that marriage, if you will be successful.
Mm. Dr. Bailey, you and I are both in private practice currently, but we're seeing a lot of consolidation. We're seeing it in practices. We're seeing it in hospitals. Is this a positive trend that's going to lead to better patient care, do you think?
I think the verdict is still out on that. Like Dev mentioned, I think that a lot of these, marriages and mergers of practices and hospital systems and the rush to employment is for the wrong reasons. Physicians are desperate. They want to keep practicing, and they know they can't make it on their own. But working inside of a large system may not work either. And the payment models are so important. Do you go with the bundled plan? Are you in an ACO? Or are you in a traditional type of indemnity plan? I can't even say it.
Not an easy word.
Yeah. And so I think that, and one of the things that AMA is doing now is partnering with RAND, looking at different practice and payment models around the country for different specialties and trying to see, okay, well, what really works in what particular situation? And I know, and I think we all feel in our hearts that it's not going to be a one-size-fits-all type situation. I remember I was at a conference representing the AMA Council on Medical Education a number of years ago, and we were just beginning our transformation of medical education project, which is now one of our 3 primary goals for our strategic plan. And so I was sitting in a small group about the size of one of these tables and discussing something, and someone from one of the academic medical centers said, well, I think, let's just establish at the beginning of this conversation that the best way to practice medicine, the best health care is delivered in a large integrated system. And there was agreement at the table. Nobody said a thing until I piped up and said, no, I think that there's lots of ways that good care can be delivered. It's not a one-size-fits-all type system.
Yeah, and with the site of service offset that we don't seem to be able to shake, it's interesting that the same test could be done in a doctor's office for $800, and in a hospital it's $3,000. And I don't know how that's better and lower cost care.
I'm real concerned about the cost of care actually going up because of these consolidations and mergers. Because the like you said, the site of service differentials, hospitals can charge more for things than we do in our offices.
Right. Let's get on the topic a little bit of the policy implications that we're seeing in the future trends. So the majority of docs are expressing a lot of doubt about where things are going. We've heard that already. And 90% seem unsure about how the health system will be or how they're going to fit into it. And obviously, the foundation feels it's really critical for physicians to have a voice in where we're headed. So, we talked a little bit about how ACA was graded by the over 600,000 doctors that we surveyed. What do you think is missing from ACA? What is good and what is bad? And, in my perspective, it seems like we ought to keep what works and get rid of what doesn't work. So, Dr. Sangbhai, tell me what your thoughts are on that.
So overall, I think the idea of getting more individuals access to insurance is a good thing. It enables individuals to get health care. The exact vehicle by which we do that is really where the debate lies. But if we look at a part of the ACA that often gets unmentioned because of the delivery side of things, I think one of the good things is the work that the Center for Medicare and Medicaid Innovation has done with some of the projects that they've put out to really spark innovation among the delivery community, among the physician community. And I find that particularly exciting because this is an opportunity to redesign the healthcare system by physicians for physicians. So there are some elements of it that are good. I would also say that one of the other challenges is it doesn't get to some of the things that haven't already been mentioned around creating a sustainable healthcare delivery system, whether that's through bureaucracy relief, reimbursement relief, whatever it is that we need. In the absence of that, some of those things will be short-lived.
Yeah. Dr. Basil, what do you think is positive and what has been negative for you in your practice?
I think Secretary of State Burwell, or Secretary of Health and Human Services Burwell, is very good at pointing out all the positive things about the Affordable Care Act. In my own practice, yes, there have been a few success stories where people that have not had insurance have been able to come in and be seen. My frustration, I think, is, again, the reimbursement kinds of issues. SGR is one thing, but there's been, over the years, a discriminatory problem with some states reimbursing at a higher rate than others in Medicare. I started an HMO 20 years ago, run by Family Docs. And ultimately, this HMO went belly up because the per member per month payment in rural Minnesota was something like 1/5 of what it was in other places in the country, and it was unsustainable. My concern is we're putting more and more people on medical assistance. That's not sustainable. There's a difference between access and availability. The ACA is increasing access. But if I give everybody in Washington, D.C. a ticket to Fiddler on the Roof, which is in town, they all have a ticket, but there's only a few seats there. And my concern is availability. We need more physicians, particularly in rural areas. I'm an old guy, and I think mad cow disease is going to start in eventually, and there are people that say it's already set in. But that's my concern. You need to provide the appropriate amount of funding if you're providing the insurance, and you need to provide the availability, especially in rural areas, for that care.
Yeah, Sue. Things I liked was, as a gynecologist, obviously well-woven care, access to birth control, which is important in my practice, keeping people on insurance till 26. But one thing that really has a lot of the doctors where I am very frustrated is the grace period issue with subsidized health insurance exchange plans, where if you deliver the care, if the patient doesn't pay their premium, the insurance company recoups the money, which seems like
From
it's
us.
from the doctors.
Yeah.
So you can't take the care back. So talk a little bit about that, and how do you deal with that in your practice? That's a difficult problem.
It's a very difficult problem, and it creates a lot of extra work on the front end before you even see the patient to make sure, okay, are you really insured? Are your payments up to date? If we had real-time verification of benefits and technologies that a lot of other industries seem to manage, I think some of those concerns could be obviated. But it's I think a lot of folks don't realize that a lot of that burden ends up on the physician if the patient is not able to pay their premiums, which are often somewhat high, and then when they realize they've got a multi-$1,000 deductible, oftentimes they feel like they don't have insurance at all because they're still having to pay for everything out of pocket until they reach a certain point.
Yeah, what we're seeing is a lot of patients got insurance because they had a problem, so their well exam may be covered, but they're coming in because they want the problem handled that has been a lingering chronic problem for a long time. But then they found out they have a $5,000 deductible, so they bought insurance they essentially can't use.
Right.
And have you seen that as well?
Yeah, I think the other challenge is that many patients who have purchased insurance, quite frankly, don't know what they bought.
That's right.
And so they're looking for somebody to help them understand what they've purchased. And so you can have that dialogue on the front end, but many patients don't know. They think they've paid their premium, maybe they've not. In some cases, individuals will carry a health card, but it's for a narrow network, and so they don't know that if the physician's group or the individual doctor is in network but may not be in network on this plan, add the high deductible health plan to it. I think we need health insurance 101 as part of this entire paradigm for people to fully understand what they're purchasing and what the pros and cons are of everything that's out there.
I had a patient the other day, and this isn't the patient's fault. Many of them have never had insurance.
Right.
So they said to me, well, I can't believe this deductible is so high. I'm going to drop this. I'm going to ask for a refund.
Yeah.
Apparently, you don't know that they don't give you a refund. So you're right. Health Insurance 101 would be really useful. So that's the level of understanding of some folks, which is understandable. They've just never had it. Right. So what do you think would be the two most important things, or you can give me more than two, but I'll ask each one of you, what would you like to see be the two most critical issues that policymakers and lawmakers need to be attuned to in 15 regarding healthcare? Start with you, Sue.
Well, I think number one, I'll say it again, SGR. I would love for it to be looked at before 2015. I think there's an opportunity before the end of the year to get this the SGR fixed. If not, in 2015. And the regulatory tsunami that is getting ready to overwhelm physicians with the, first of all, we've been subject to the sequester, so that's given us a certain cut. Then the e-prescribing penalties, the quality issues that we've been getting bonuses for the past couple of years, we're going to start getting penalized if we don't do them. Right. The EHR bonuses are going to become penalties. And so all of these things are going to start stacking up and stacking up and stacking up. The value-based modifier that was in the Affordable Care Act that I wish someone could tell me what is an efficient doctor and what is an inefficient doctor. That's very much in the eye of the beholder. And so if we could stop the earthquake that's generating the tsunami of regulations that doctors are having to face, I think that would be a tremendous advance.
Yeah, I think Dr. Ray said it very well. The quaking under the feet. You just don't know where you're going to be next. Mm-hmm. Dr. Sanghvi?
I would agree with Sue. I mean, I think that the ability to create a sustainable reimbursement paradigm is critical to the future. Coming from medical school, I think there are two other policy issues that really require some degree of priority. The first is medical student debt. We know that the burgeoning amounts of debts that medical students now face upon graduation is directly correlated to their specialty choice. And if we're looking for workforce distribution that mirrors what the country needs, we're going to have to find a way that the debt burden matches specialty choice in a way that's favorable. And the second is the next stage of education, which is graduate medical education. I think Walker and Tim outlined it nicely that if we don't have a sustainable graduate medical education program, we significantly risk our ability to have a ample and sustainable physician workforce.
Yeah, coming out with a home mortgage before you have a home is
it's $250,000.
$250,000 is a lot of money, no matter who you are. Yep. Bob?
Basically, same thing. One thing for me, one for my wife. Get rid of the paperwork. Let me take care of patients. That's number one. Number two, for whatever reason, my wife would like to see me around more. We need to increase the supply of family docs.
Yeah, I would mirror those comments exactly. Yeah. Well, I think that that covers a lot of the topics we're all looking at. I hope it gives all of you a flavor of what's going on sort of a day-to-day running of our practices in clinics. So at this time, I would like to open it up for questions. Yes, sir.
Thank you, Dr. Valenti. I have a question for Dr. Sanghvi. Given the discussion on Health Insurance 101 for patients, what do you think about medical students coming out into this new world? What do the medical schools need to be doing to prepare doctors for the challenges they're going to be facing, not just with practicing medicine, but the other avenues that they have to?
That's a great question. I think that all the interested groups, whether it's the Association of American Medical Colleges, certainly the AMA, are all focusing on the curricular reform that we need in medical school. I think the challenge is having a good sense of what you need to know, and it's time limited, and you can only put so much stuff into a curriculum. Something has to come out at the same time. But I would agree that there are specific med schools, in fact, that are now focusing on the business of medicine as a component of education. But I also think we've got to create avenues for those who actually want to go down that pathway. So it may not be something that's in a traditional 4-year curriculum, but maybe a 5-year curriculum where you're really trying to create future leaders in medicine. It's certainly something we've been looking at Duke in terms of innovative ways to do medical education.
Dr. Valenti?
Yes.
We've heard a lot of discussion about EMRs this morning and by the panelists. What suggestions would your panelists be able to give us to make that a better system? Dr. Ray said it's here to stay. We've got to work on what we can do to improve upon that.
Well, I'd like to answer that, and I'll let someone else do that too. But I think what a lot of people are very confused about is that there's so many EMRs, none of them guarantee they're going to be there later when you need them. So a number of them have folded. But there's no intercommunicability among them. So when you talk about this advanced age of future medicine where you could get someone's EMR from another practice who's using a different system and get exactly what they have downloaded to your system, so there'd be lack of duplication. It's not that easy. Currently, it's just coming in as scanned in information, and there's no intercommunicability. So that's a real problem. Anyone else on that?
Yeah, I'll jump in. The AMA, in conjunction with other entities, and I think somebody from Duke was involved with this as well, Dev, issued a white paper earlier this fall identifying areas to improve EHRs, to improve patient care and improve productivity. And they came out with 8 specific ideas that would improve EHRs, enhancing their ability to provide care, supporting team-based care, promoting care coordination, product modularity and configurability, reducing the cognitive workload, data liquidity, facilitating digital and mobile patient engagement, and expediting user input into product design. In other words, make them usable, make them user-friendly, make them talk to each other.
And sometimes you wonder when you look at some of these programs, did a doctor ever look at this before someone put it out? It's amazing.
Well, I think the problem also is the meaningful use guidelines or mandates. They're silly. I've had an EMR for 10 years. It's been a good product. It doesn't necessarily fit all the categories of meaningful use. They need to get rid of that whole concept of 1% penalties or 6% penalties or whatever.
Well, they're going up every year. So.
Yeah.
Mr. Hughes?
Robert Hughes.
Dr. Hughes, excuse me.
New York. Conflict of interest being that I'm a small business solo private practicing physician in this world right now. And I view the drive to consolidation as really not because of any inherent improvement in quality or even in cost efficiency. It's really driven by the insurance monopsony powers and the unfair antitrust situations we have. What that has allowed is the creation of this networking model. And I think the networking model is nothing less than an indentured servitude. And that, I think, is a real problem. And once you're forced in that network, you're forced to behave within that network. Medicare is clearly the biggest network out there, but this concept of network power is now metastasized even into the large group practice models, the corporate practice medicine models, where physicians are forced to refer within group. It really does nothing for small business creativity and innovations that we know have driven this country from the beginning. So I am very concerned about that, and I really think the right to private contract is critically important, whether it's the Medicare Patient Empowerment Act or whatever, that patients have to have the right to see a doctor of their own choosing. Thank you.
Yeah, and to mirror your comments, what we're seeing where I am is this huge narrowing of networks. And how quality is defined may be quite variable. You may be taking care of some of the sickest patients where you live. So maybe your outcomes aren't the same. Say you're a heart doctor who sees only the sickest patients, only takes care of the worst cases. Well, your outcomes may not be the same. Yet you might be dropped from a network based on that. Is that really what we want? Those are the people that are working the hardest with the sickest patients, and yet those are the people most likely to be dropped from these narrowing networks as they try to focus down on who can participate. So I agree 100%. Any other
And unfortunately, the Hammurabi Code, I don't know if you remember that, this lawyer thousands of years ago or whatever came up with this code as to practice guidelines. And if you followed the practice guidelines and somebody died, it didn't matter. If you deviated from those guidelines and somebody died, you lost an arm. Unless they were a slave, then it was just a finger. But there were substantial penalties for not following the guidelines. And because of that, nobody tried anything new for 400 years, but also nobody took care of sick patients because they were afraid they'd have an adverse outcome, and some lawyer along the way would say, hey, you deviated a little bit from this guideline. So it does, unfortunately, influence the availability of specialists and anybody to see a particular patient. If they're too sick, hey, it might look bad in my record, so I don't want to see somebody who's sick.
We had a question over here. Yes.
I was asked this last week. I'd like to ask it of you, all three panelists. If you could, 30-second soundbite with the president, what would you say?
I would say, I want to play you one-on-one. I'm 20 years older than you are, but I think I can still beat you.
Deb, what would you say?
I think that, first of all, the desire to improve the health status of our citizens is noble, and I think has to be recognized as a good thing. How we do it, I think, is the challenge. you've got to have workflow solutions to improve patient care. You can't have too much regulation and too much law. So we've got to find a way to take great ideas that happen in this city and really bring them into places like rural Minnesota. And that requires workflow solutions that are driven by those individuals that are actually delivering health care.
I think I would ask, since they've already asked all the other things, I would ask the president not to veto any attempt to get rid of the IPAB, which is the Independent Payment Advisory Board that's part of the Affordable Care Act, that allows the president to create a special commission of presidentially appointed individuals who can further reduce Medicare payments if they are going up too much. So there would be double jeopardy with SGR reducing payments and the IPAB reducing payments. The board has not been appointed, it's not been created, and so far has not been needed. And I think that when Congress, hopefully next year, sees fit to take IPAB out of the Affordable Care Act, that he'll agree it wasn't such a great idea after all.
And I would just add, I would ask the president to look outside the lobbyists and start listening to the people taking care of the patients, who are the physicians, and remind him that while not everyone is a physician, everyone is going to be a patient. Everyone's a patient. Everyone in this room is a patient. Everyone's going to be a patient. And at some time or another in your life, you're going to need someone to do something extraordinary maybe. And you hope that the time you need that extraordinary person, they're going to be available, they're going to be well-trained, and they're going to do it with a smile on their face. And I hope we never get to a situation where that person isn't available. Sir.
We've made the diagnosis, and I think every one of you have alluded to it, that we do have a physician's shortage. We've been making that on the life since 1980. And the diagnosis is made. Some state government officials, and this is firsthand, draw comfort in we can produce more physician extenders. So we can plug that hole. I'd like some comments on the practicality of treating the physician shortage with producing more physicians extenders in programs that are 2 years, essentially about 2 years. Can we treat the physician shortage problem by producing more physician extenders? With all due respect to the role for physicians extenders.
Shakespeare said, the eye sees what the mind knows. So when you look at just the number of clinical, and by the way, as a matter of disclosure, I work with midwives and nurse practitioners, but I don't expect them to diagnose everything because they haven't seen it. When you look at the offset of number of hours of training, it's 20 or 30-fold greater number of hours of training of a physician versus, say, a nurse practitioner or midwife. And I'm not disparaging them. I work with them, and they're great. They have a role, but they're not a replacement. Any other comments?
Yeah, I think every member of the healthcare team is vital. And I think medicine is best given when everybody understands, with I think a perfectly physician-led team doing the job. But hiring more nurse practitioners to fill in for doctor spots, we have a shortage of nurses as well as a shortage of doctors. And we don't need to do anything to exacerbate the nursing shortage by putting them in positions where they may not be adequately trained. I think that there's a maldistribution of physicians as well as a shortage of physicians, so we need to train more physicians. We need to get them in the right spots. Very excited about the workforce research that the foundation is sponsoring. I hope that's going to be very, very helpful. But when you look at maps, and there's some great ones on the AMA website that superimpose where physicians tend to practice, where nurse practitioners tend to practice, where physician assistants tend to practice, where nurse anesthetists tend to practice. It's not like the physicians are all in the big cities and everybody else is spread out into the country, where everybody is kind of concentrated in the same space. So I think the arguments that have been made that physician extenders are more likely to go out into the rural areas. Have you seen that, Bob, working in a rural area yourself?
Yeah, in Minnesota, There is a concentration in the metropolitan areas. I should have a disclaimer, because I do have a PA that works with me, who's a superb individual. The problem is he cannot replace a physician. It frustrates me to no end when I send a patient off to a consultant, send a patient to a dermatologist or a neurosurgeon, and nurse practitioner sees that patient.
It's extremely frustrating.
It's not good for healthcare.
I would like to ask any of the panelists, how is hospital consolidation impacting patient care, and is this a positive trend?
I mean, I can answer. I think that the challenge with consolidation is that the need to have market size is becoming increasingly important for health systems, because in many cases they are the safety net provider for patients who can't otherwise pay. So with consolidation comes some safety as well. I'm not sure whether or not it's necessarily helping or hurting access. Right now I think the jury is still out to really determine what the impact is. Our approach in North Carolina has been to be very cautious and be very smart about the type of relationships we form, mainly because we don't want to impact the ability for patients to have access to good health care. But we also know that the emergency room is not a place to get primary care. So you have to look at this in tandem. What are you going to do to increase your physician base so that you can create accessible primary care if hospital consolidation is the pathway you want to go down? I think the other challenge is if we look at those hospitals that are being consolidated, it's oftentimes smaller community rural hospitals that are having a hard time staying on their own bottom line. So the forces that are compelling them to join a larger system are survivability as well. And in many cases, if they're the largest employer in town, for example, there are significant implications downstream. So I think there's so many factors that play into this. Whether or not it impacts patient care, I'm not exactly sure, though.
Thank you.
STR has a lot of play on the panel today. I heard it mentioned several times. But STR doesn't affect my daily workflow. You're either a Medicare provider or you're not. And you talked a bit about workflow and paperwork problems. The real elephant in the room is ICD-10. And I can get denied just by putting a decimal in the wrong place. And there's a number of codes that no one's going to know. Can you just briefly speak some more about ICD-10 and how we can avoid that?
Yeah, I'll just make a comment. I don't know. I mean, I think we need to push to avoid it. There's just nothing in it that adds to the quality of care. But I know what will happen when we switch to it. As you know, we are going to be ground to a halt.
Right.
Much like we were ground to a halt when we implemented EMR, electronic medical records. My office went to essentially half-time for almost 6 months. Now, forget what that does to the bottom line and the ability as a small business, and by the way, doctors' offices are the 10th largest small business in the United States. Forget the fact that that impacts my ability to pay my employees, so I didn't pay myself for almost 6 months. But you just can't see patients. You're just, I mean, all the codes I know in my head now are all going to be changed. So you're getting a whole new vernacular that you're expected to implement immediately. And it just, it does nothing to help patients get better care. I don't see what it does.
But it's not for our benefit, not for patients' benefit. It's for the insurance company's benefit and the health czar that they're appointing sooner or later. The more data you can collect on patients, the more this health czar will like it, because the EMRs will all feed into a huge computer in Washington, D.C. And no, the FBI won't have any information access there.
You asked what we can do, and I think one of the things is really highlighting these exact type of examples on how implementation is really going to impede patient flow, it's going to create bureaucracy, and it's going to impact access. It stuns me that if, as a family physician, I take care of a patient with diabetes who also has kidney disease and can provide outstanding health care, my first diagnosis might be diabetes, my second will be kidney disease. But in the new age, I have to diagnose with one code, which is diabetes with kidney complications or renal complications. If that gets kicked out of the system, there's a back-end edit. Who's going to process that? If it's not me, you have to have somebody do it for you. That's going to slow down the ability for have patient throughput. This is an access issue. It's not a coding or billing issue. And it goes back to the question we had earlier. I think the biggest challenge with EMRs, which are supposed to help with 10, is that they're being implemented as documentation tools, not workflow tools. If we implement it as a way to get patients in and out happier and healthier, it would look entirely different or marginal or markedly different from what we're doing right now.
Very good. Thank you for your questions. Thank you very much. And thank you all for attending. We really appreciate your being here. Some of us will be able to stay afterwards. Dr. Bailey has to go to another conference, but and of course we have Tim. You some closing comments? Oh, Jason.
Yeah, we're right on time. We respect all of you, your time, your schedule being here. We just have about 10 minutes.
Okay, very good.
Thanks.
Absolutely wonderful job, Joe, and you and your panel. Terrific job. A lively and interesting discussion. And once again, if we could do that. They have all come a long distance to be with us, and we're very grateful to all of you for doing that. Wrapping up our program will be Lou Goodman, Ph.D., President of the Physicians Foundation and Executive Vice President and CEO of the Texas Medical Association. Dr. Goodman is an economist with a decades-long perspective on the American healthcare delivery system. During his 27 years of experience at the TMA, he has leveraged his expertise on critical issues such as physician shortages, tort reform, and the legislative, economic, and political determinants of health reform on behalf of his member physicians. Lou?
Well, my closing remarks will be brief. I want to thank our panelists for an excellent conversation on the issues affecting medicine. I want to thank Dr. Ray for his review of our National Physician Survey, and to Tim Norbeck for being our wonderful MC. Every year, the Physician Foundation, for the past 3 years, puts out what we call a physician watch list. This year, our physician watch list identifies key topics affecting physicians and patients in the year ahead. And I'd like to give you a preview of that 2015 watch list. We call our first topic of the 5, consolidation hits the gas pedal. As our panel pointed out, the increased rate of consolidation among hospitals and health systems continues to drive smaller and independent practices into larger systems, potentially decreasing competition and increasing costs. As we heard from the panel, the jury's still out. Our research, however, is showing that competition is being decreased, which typically drives costs up. Our research also shows that more than 2/3 of employed physicians, those doctors in those systems, 68%, are concerned about their ability to make the best decisions for their patients, and they feel that their ability to do that will be impaired. Our second issue is entitled External Pressures Adding Stress to Physician-Patient Relationships. Our research bears out what we've heard from our panelists. 80% of physicians describe patient relationships as the most satisfying aspect of medical practice, and Dr. Ray made that point very strongly. Yet red tape, administrative burden, interfere mightily in the doctor-patient relationship, and that's something that seems to be one of the themes that we've heard today. Third is ICD-10, and we've talked quite a bit about that, and we're concerned about its impact on physicians' practices and hospitals. 50% of respondents to our 2014 National Survey of Physicians indicated that ICD-10 implementation will cause them severe and costly problems in their practice. Pairing this with the fact that 1/5 of physicians' time is spent on non-clinical paperwork, the amount of time physicians will be able to spend with their patients will surely diminish in the future, just the opposite of the direction we want to go. As Dr. Bailey pointed out, our medical societies and AMA are asking Congress and CMS for another 2-year delay in implementing ICD-10. The fourth item on our watch list is the need for cost of care transparency. Not knowing what most things cost in health care in our healthcare system is certainly causing frustration and fear among patients and from doctors. The unexplainable site-of-service payment differentials between hospitals and private practice, as pointed out by the Congressional Advisory Committee, MedPAC, it's certainly increasing costs and confusion. And finally, access to physician care is number 5 on our watch list. We heard from our panel the need for more physicians, yet our research shows that 44%, almost half of the doctors surveyed, plan to reduce access to their services in 2015. They are going to reduce the number of patients seen, retire early, work part-time, close their practices to new patients, and seek non-clinical jobs, which could lead to the loss of tens of thousands of full-time U.S. physicians. We've actually calculated the FTE, full-time equivalent to that. And it's quite frightening. I've had personal experience with the frustration of the red tape and administrative burden. My personal physician of 20 years is himself retiring earlier than expected because of red tape frustrations. And I'm pretty frustrated, too, so I like him. I guess I'll like the one he's referring me to as well. A key way to help healthcare analysts and lawmakers better plan and prepare for physician shortages at the state and below is to use real-time actionable data, like the information available on our Future Docs research tool developed by University of North Carolina. And as been mentioned, it's on our website, and it is free for use by anyone. We want to make this available so that we could do concrete analyses on what the future might bring. These and many more challenges are in store for our physicians in the coming years. I want to thank our panelists and everyone here again for participating. Our panelists provided great candor and insights into the key challenges and issues they face, their reflections on the need to ensure our physicians can continue to deliver high-quality care to their patients, which, as we've heard, is the number one reason that these fine men and women go into medicine in the first place. To the members of Congress, and I believe Congressman Rowe was here earlier, very pleased, the media, the research think tanks, congressional representatives who took time to hear from us directly from our doctors on this changing environment. We appreciate your willingness to listen and to engage with us on the current state of medicine. There are many ways we can continue this conversation, so we encourage you to stay in touch with us, with the Physicians Foundation. On the screen, there it is. You'll see that there are various ways you can keep in touch with us through social media, online media. We have a channel with Forbes. We publish articles, typically monthly, but Tim and I took a little break the last few months, but we'll be back on in January. And there are other ways. And finally, the members of the Physician Foundation, and there are several of us here, will be sticking around a bit longer, so please don't hesitate to approach us with additional questions, comments, and suggestions. Thanks again for participating, and we're adjourned for today.